So now I would like to introduce our first speaker today. Rick Cooper is the CEO of the Everett Clinic. There you are, Rick. I've known Rick for many years, and I am delighted that he agreed to speak with us today. The Everett Clinic is a national leader in transparency and value-based purchasing. Mr. Cooper joined the Everett Clinic in 1977 and became the CEO in 1985. Throughout his tenure, Rick has driven the Everett Clinic to focus on quality improvement, service excellence, and lowering costs. As a result, the Everett Clinic has received national media attention in Business Week, U.S. News and World Report, the New York Times. In 2012, the clinic was featured as a high-quality, low-cost healthcare provider on U.S. Healthcare, The Good News, a PBS report. Under Rick's leadership, the Everett Clinic has been named for a number of awards as a great place to work as well. Rick is also on the board of the Washington Roundtable, one of our valued sponsors for today's event. Rick is here to make a call to action from the provider's point of view, why it's important for purchasers to partner with providers to lead change to value together. So let's all welcome Rick.
It's great to be here. Nancy invited me to share some of our thoughts about value-based care. That was a very thoughtful invitation. She limited me to 30 minutes. And for those of you who know me, that will be my biggest challenge. I'll also, as the title states, this is a highly collaborative undertaking. And I recall Carolyn inviting me about 10 years ago to come down to the big city. You're from Everett, Seattle's the big city. And share our experience, and I'll talk about this in a little bit, related to how we manage the fastest growing line item in the medical insurance premium at that time, which was the cost of prescriptions. And lo and behold, King County worked miracles to manage and control that cost. And it's an example, this is a point I want to make, it's an example of when a provider can communicate directly with an employer, a plan sponsor, communicate directly with to share issues, needs, opportunities, and then magic indeed can happen. So I'll start with a metaphor. We've been using this burning platform at the Everett Clinic for 2 or 3 years. Now I'll tell you that I'm really a pretty upbeat person by nature. I'm an optimistic person. But if you look carefully, I'm on the top level. And this is a real issue in our society, the cost of health care. And we fundamentally believe at the Everett Clinic that it's too darn expensive. So that's the assumption that we're making. You all know about how, I'll have some slides about how much more expensive it's becoming. The other thing is that we live in a maturing industry and it's rapidly consolidating. Now, time will tell whether that's good for patients and good for the industry. But in point of fact, in our market, 70% of all care, inpatient and outpatient, is under the purview of 4 organizations. So that's a reality. It's also true that the industry is transforming. My view is a way out of this mess is through innovation and transformation, but it's happening quickly. It will be very disruptive, and I'm glad that the comment was made that it will be disruptive. And we're not accustomed to significant loss of employment and shifts, but I predict that's going to happen. There's a demand for transparency. It's a complicated industry. You should insist upon it. My goal this morning is to try to translate this complex industry into a few simple levers that you can pull to try to move the dial and make care more affordable. Pricing, unbelievable. You know how confusing and variable and misunderstood it is. It is. And we all are talking about what we can do to reward those who deliver value. And so to level set, for me, a value is simply improving health, reducing resource consumption, improving the patient experience, which isn't all that great right now, and for those who deliver care, improve their experience as well, because there are a lot in this industry that don't enjoy what they're doing. So how about this question? Does it cost too much? Of course it costs too much. And so many of you have seen these slides about the cost of care in this country versus others around the world. And we're not the least expensive. And when you're starting to zip up to 20% of GDP, are you kidding me? Really? So that's not sustainable. And all of us are paying more for care out of our pocket. And I know many of you are involved in the human resource function. And I'm an employer too. And we want to attract and retain the best possible people. And we want to retain these people throughout their professional work life. And we're going to invest in these people. And when I ask what's important to our staff, healthcare coverage is number one. And making it affordable is very important. And being able to access care on a timely basis is very important. And this I think about a lot in our quest to move towards retail medicine and high deductible care. I think about this a lot. Lots of people aren't getting care. It's too darn expensive. I'm going to particularly talk about that as it relates to behavioral health. And I'm sorry, this is kind of a busy slide for some of you who can't see it, but it's kind of where the dough goes. And it's a lot. There's a lot in this medical industrial complex, and there's a lot of people around the trough. Okay. I want to talk about the hidden tax. The hidden tax. And all of us as employers focus on our own costs. But this you could go to the New York Times, I believe. There's a lot of sources of this data. The chart on the left is Medicare spend, and the lighter, the better. And in point of fact, this state is below national average. In this state, we have among the most efficient delivery systems and the lowest cost for Medicare spend in the country. On the right, it's what you and I are paying in commercial spend. So how do you like average? Are you average? That's average. And so the industry, me, others in the industry have a cost base, and we find ways to try to cross-subsidize what the spend is in Medicare. And I'm not even talking about Medicaid. There are about, I don't know, 15 to 20, I'm not exactly sure. Some of my colleagues, Dorothy probably knows this, knows the answer, but there are 15 to 20 other states, and Medicaid at least will pay primary care Medicare rates, not this state. So it's the degree of subsidy. I'm not going to put a Medicaid chart up. Okay? So are you getting what you pay for? You know, there are many economists, people a lot brighter than I, who question that. And here's the scoring in healthcare ranking. And down at the bottom is the United States. We have the lowest life expectancy at birth. Highest spend, lowest life expectancy. The disease burden is higher. I would appreciate having some pastry. You know. The U.S. has high rates of medications and lab errors. How about quality? How are we doing? How are we doing? And is there variation? You know, this is becoming more known. But the variation in our industry is unbelievable. Now, where I operate, we've got about 600 providers. And I'm telling you, we've got variation. There's variation with how patients present, but it's pretty darn significant. And the variation extends to this concept called pricing. Pricing. And so the average price of an MRI in the U.S. is higher than other countries. The average price of angioplasty or bypass is higher in other countries. How about pills? How about pills? I love pills. Higher. There's a trend, higher. And then there's variation right here in our state. How about that? And I'm not wanting to pick on anybody. I just think that we all will do better if there's more transparency in our industry. So back surgery, there's a swing in pricing. Knee or hip replacement, there's a swing. Wenatchee Valley Hospital. Wenatchee Valley. Is there anybody here from Wenatchee?
Well, I am.
There's Jaybird. 23,000. And I'll tell you, they recruit among the best providers in the country in central Washington. And there's all kinds of disparities in hospital charges that you know about. So we can't debate that one. So you know it's expensive. You know there's variation. You know that there isn't the value proposition currently in our industry. Here's the irony. We all want the same thing. And you want high quality, affordable care that keeps your employees healthy. And patients want high quality, affordable health care that keeps themselves or their families healthy. And guess what? So do providers. We all really want the same thing. So in this, if this was easy, we'd have figured this out, you know. But there are, I really believe there are a few levers that you as purchasers can utilize that over time will move the industry and make a difference. And these are the categories. Transparency in the broadest sense. In the broadest sense. Clinical models, they're not all built the same. They're not all built the same, and we'll talk about some of the clinical models that really add value that you need to ensure exist in the delivery systems you're contracting with. And then this issue of linkage on benefit design and financing. You can throw in the right incentives. So boy, I had a conversation with some of you in this room yesterday afternoon about value and transparency. And it was plan sponsors, employers. Boy, if I were you, I'd insist on it. Remember that one. I'm going to come to that slide. If I were you, I would insist on transparency. And you know the reasons why. They're paying more. In our shop, the first day a new teammate starts working with the Everett Clinic, we talk about this. We talk about this. Our patients are going to be paying more money for care. And it is our fiduciary duty to ensure that the experience is the best it can be. We do everything we can to improve health. We reduce the resource consumption. And then our pledge as an employer is to try to create a great work environment so we can accomplish that goal. Patients need to make informed decisions. So there's a lot of work in this state on shared decision making. And fundamentally, competition, even though there's much consolidation, in my view, we still have sufficient competition to improve the system. The Washington Alliance, it's not a bad outfit. It's not a bad outfit. And if you're not participating, if you're not a member, you should be a member. You should invest in this wonderful organization that was really focused on trying to share more information and make this complex industry better understood. And fundamentally is working hard to be very, very visible about the quality of care. I have a request for everybody in the provider community to do what we do. And you can go on our web site and you can find our prices. Now, is that what our patients want? Not necessarily, but it is a step in that direction. Your price estimators talk about variation, and what price estimators will estimate is going to be the out-of-pocket. That's a cottage industry that's growing because there isn't sufficient transparency. Step one is just to list your prices. You think everybody would appreciate at least an initial effort? We are spending a lot of political capital and thrash on an all-payer database. I mean, all with the objective of trying to bring more transparency to this issue. How about everybody just list their prices? And as an employer, you should insist upon it. You should be all over me about being transparent in the broadest sense. And it ought to include how we're performing on Nancy's patient experience. How you doing, the Everett Clinic? Well, not bad, but not great. How you doing with quality of care? What's your prices? And I will not accept that this is proprietary because I've negotiated a deal with a health plan. I mean, there's no other industry where it exists to the degree it exists in our industry, and so demand it as an employer plan sponsor. So you're going to hear more about about behavioral health generally, mental health generally, and in our setting, we have integrated behavioral health into our clinical model. So the Affordable Care Act calls for this. We're working hard to bring together behavioral health delivery and physical health delivery. And every community has a different model. And I know there are lots of great innovative solutions in different communities. For us, our behavioral health asset is one of the crown jewels of the Everett Clinic. One of the crown jewels. We have 40 to 50 providers integrated into our primary care. And we have no barriers inside the Everett Clinic once you're an Everett Clinic patient. My request of you, in the insurance world, behavioral health is considered oftentimes a specialty. I would ask you to join me in requesting that that be considered a primary care service. And so what does that mean for the patient? In downtown Everett, Washington, it means rather than a $40 copay, it's a $10 copay. And in order to manage these complex patients with comorbidities, there's a difference between a $10 copay and a $40 copay for timely access. And the location of that service close to the primary care provider also is pretty darn important. And we have learned much over the years on the role of behavioral health. The Boeing experience really was designed, this was something that we participated in along with VM and one other provider, Valley, a hospital down in Renton, to care for the most complex patients, prospectively identified. It was a multidisciplinary team. And the results of that effort are published in Health Affairs. So you can go to Health Affairs and you can see how we performed, but it did not control the spend in comparison to the peer group. It didn't control it. It reduced it over a 2-year period for that cohort. Okay, we were talking about pills. Love pills. And so we've developed a competency over the years in managing this very, very important part of our medical system. And so as a purchaser, you just need to have your eye on this one. And the delivery system can impact how prescriptions, when they're written. It's all based on evidence. We're north of 92%. We have a high degree of collaboration in health, in this state particularly, and we have a friendly competition with group health. We compete with Kaiser in the Oakland area for who performs the best in terms of generic prescription. The problem with this one, our savings now are somewhere between $100 and $125 million a year in comparison to the average cost of prescriptions in this state. And this state is less expensive than other states. So it is true that there's much innovation and much great work being done in Washington State. And if you overlay our cost to the rest of the country, we'd be in pretty darn good shape. But we can still do better. But the cost of prescriptions is a lever, and the delivery system, you should insist, addresses how to appropriately prescribe, and it can be a significant cost saver. Imaging. This is an example of providing information. And I will tell you, you and I need to talk about whether or not I am, as a provider, caring for your workers, covered dependents, and getting timely, actionable information from the TPA or the health plan. Because I am not. Might surprise you. I am not always. Sometimes I do. And in this instance, I did from an outfit that's located in Mount Lake Terrace, Washington. And in this instance, Primera informed us that our spend was Not as good as we thought it was in comparison to the peer in the region. It required information. We took that, put together a multidisciplinary team, built in evidence-based guidelines, built it into workflow and care flow, and then reduced utilization by 40% by engaging our clinicians. Because we have the information. So, Carolyn and I now should have another project. She invited the Everett Clinic to come into Seattle. A long time ago, didn't. But we're coming close because we're coming to Shoreline. Okay? And so we should sit down and we should be sharing information. Here's our utilization for our population. And here are the issues that we're confronting. And we can get around this. And how together can we support one another, whoever the contracted provider is, to address issues that are unique to your own setting. But to have that dialogue, it's the together, it's the conversation. This, it really is an outcome of our Boeing experience, and we now are developing, everybody has their own terminology. We're referring to it as personal care teams. It's a multidisciplinary intervention that includes oftentimes a general internist and behavioral health and a clinical pharmacist and a health coach to manage the most complex patients. We have 2 of these pilots. The only problem is there's no relationship with the financing. We're doing it because it's the right thing. And fundamentally, one of the solutions to the spend is identifying the 5 to 10%. It's the 80-20 rule. Only it's 5 to 10% of all populations are going to generate the biggest increase in spend. Our challenge is to identify those, have this multidisciplinary intervention, and connect with patients in a fundamentally different way. And so we do this with end of life and palliative care. We have a partnership with palliative care of Snohomish County and the Sisters of Providence in this instance. And these folks are in our primary care departments. We have, a year or 2 ago, 70% of all patients who died had advanced directives, and our goal is 85%. And we're trying to move upstream this conversation of advanced directives for that cohort. And we had this deal with Boeing. So we're involved in this Boeing Accountable Care Organization. And the Advanced Medical Home, this personal care team, is a significant element of that of the ACO project. So this is the work that you are involved with. And this is the lever of trying to put in alignment benefit design along with financing and rewards to the provider. And so our view is that fee-for-service medicine is fundamentally inflationary in nature. It's kind of hard to move it to something other than fee-for-service medicine. But there are ways to do it. And if the goal, affordable price and reasonable increases, I'm with you. We have a North Star at the Everett Clinic, and our North Star is to try to reduce spend 25% over time. That still puts us at a spend in this country well above others. 25%. I need information, I need data to know whether I'm accomplishing that goal, but that's our challenge. And the clinical model, some of what I talked about, but I want to make another pitch here on behavioral health. There has to be more investment in training. There has to be more support on reimbursement. And it needs to move from a specialty class to primary care. And so this volume business. You know, fee for service would be okay. And I'll use Carolyn again. So if we have a contract, let's just agree on what the increase in spend is going to be, or decrease year over year. And the intermittent payments can be piecemeal, or they can be capitation. But fundamentally, there's a finite resource. There's a finite resource. And as employers and plan sponsors, you need to think about that as you enter into these value-based payment arrangements. And you ought to be rewarding quality as a transitional. I mean, over time, you should insist on it, but you also should reward it. So I have, I think, 3 or 4 minutes left. Nancy?
Yes, sir.
3 or 4 minutes left. If I were you, the first thing I would do would be to ask that those who are fortunate enough to be caring for your employees and dependents, you should say, how about you move in the direction and listen to your prices? Don't wait for the health plan. Do not wait for the health plan to take the lead on this, because that won't happen, I don't believe. There's a whole bunch of reasons for that. But as an employer, I would insist upon that and encourage. Let's try to see if we can encourage this movement in our region and our state. And collectively, collaboratively, let's move away from a unit reimbursement mindset to some other payment mechanism. Now, the challenge is how you're gonna do this, because we're simultaneously engaged in population health as well as retail medicine. And the primary care models are transforming to achieve both objectives. But there are ways in which you can design financing and design benefits to allow both to happen. And you ought to expect the delivery systems to perform. So you should have a scorecard. Have a scorecard. How are we performing on cost, quality, and patient experience? And prospectively, have some goals. As the employer, you are entitled to that, and you should insist upon that. And as a provider, I would welcome that, as would most other providers. So, everybody benefits in a different kind of system. Employees or patients, purchasers, and providers. I'm telling you, providers want to do the right thing. They want to do the right thing. And by gosh, the providers I work with are pretty darn competitive, and they would like to see how they're doing in comparison with everybody else, because they're competitive. And I think that will produce, with more transparency and more insistence from you, on a more sustainable and affordable delivery system. So with that, I conclude. I think that you'll have time later for what, questions and
There's
answers.
a few minutes, Carolyn.
Okay.
Is that all right?
Yeah,
I'm happy to take questions. Carolyn's happy to take questions.
No.
Bob?
Yes. Dr. Crittenden.
Well, anyway,
Fire away.
I'll do it loudly.
Okay.
Is that on? You mentioned going directly between the providers talking to the employers or the purchasers. We traditionally find that very difficult because people contract with talk to a broker, who then talks to a plan, who then talks to providers. How do they do that? How do many employers actually organize and have that direct communication where you may have, if you're not a small, but say a moderate-sized employer, you may have people all over the Western Washington?
So the question was, how do you actually have this kind of conversation? And it has to be facilitated. And oftentimes, an employee benefits consultant, broker, can facilitate that conversation with customers he or she works with. The Alliance, the Washington Alliance, plays a very important facilitation and convening role to bring us together, where we can have a very candid conversation and better understand what the issues are. The way the system is evolved is in a way that has not allowed that kind of direct conversation to occur. So in our market, I actually spend a portion of my time listening to concerns of small employers through brokers, and there are other opportunities for me to meet with, so we really can listen. But I think that is, we have to be intentional about it. But you know, this is the first time we're really doing a full court press on the topic of transparency. I hope that there will be more venues where we can have this conversation and we can actually see something move.
Mark Stensager,
Hi, Mark.
Insurance Exchange. Thanks, excellent presentation. A couple of weeks ago, Phil Dyer, one of my board member colleagues, shared an article, comprehensive study of consumers, which was really disconcerting with regard to consumers actually getting engaged in the comparative process. The huge cost differences on imaging. Huge cost differences, as you pointed out, in terms of procedural costs, and virtually no change in pattern with the consumer. Are we stuck with that, or is your optimistic side saying to you, give us another 5 years, I think with all this cost shifting, the consumer is going to start getting more interested in this?
Well, that's a great question. That issue surfaced in our conversation yesterday about how to engage consumers. The cohort that was called out specifically was the 18 to 24-year-old cohort. And so as an industry, we are trying to engage them through the phone. It is, I'm not sure that as a provider community, we've been the most effective at engaging. But on the other hand, this is tough. I will choose to see my glass as half full and continue to peck away at it. But with our Boeing learnings, where we prospectively identified the chronically ill, the high spend, our challenge was to engage this population. And at the 5:30 to 7:30 session tonight, I'll give you the war stories about trying to engage. Well, look at me. I've lived a life, and how am I going to change my behavior? And that's fundamentally our challenge, is to how do we connect with and engage to improve health and quality of life. It is not easy, but accountability not only rests with the provider, but with the patient, as you point out.
So this will be the last question.
Rick, there's a certain presidential candidate who likes to speak about the corruption of healthcare providers or pharmaceutical agencies, and that's really where the savings is. So when you hear that, are you over here with that's BS, or are you over here with like right on, or somewhere in between?
Well, it's there are pluses and minuses when you're running for president of the United States. And I think that that particular candidate's on a very short leash right now. You know, there's clearly opportunity to improve. Clearly, you know my point of view on this. The spend is too high. But I've had the privilege to work with wonderful people who want to come together as a team to improve the health of the patients that they care for. These aren't bad people. They're not, and they are very, very well intentioned. We have a complex system that contributes to this frustration. And we talked this morning about some levers to pull to make that system work better. We are blessed with wonderful providers in this region. Does the spend have to be less? Absolutely. But demagoguing isn't a way to figure out how we solve these problems. Thank you very much and have a great meeting.